Going to talk on oral semaglutide and why even in the era of injectable semaglutide or injectable tirzepatide with such an excellent weight loss and all other benefit, still oral semaglutide stands because injectable drugs, people will get tired of taking their injectables. Ultimately they need some oral answers, and we have a very good molecule with us which is going to stay, and not only going to stay as for weight loss, even we have cardiovascular safety and better data with this molecule, so we can have a continuum also. So just to start with, type 2 diabetes is a chronic disorder, and as we all know, this is no longer a glycemic disease or disease of sugar. It is a disease of cardiovascular, kidney and metabolic syndrome, which is now an established term that is called CKM syndrome. And CKM syndrome is defined as stage 0, 1, 2, 3 and 4, depends on what patient is having. So no CKM risk factor, then it is stage 0. Stage 1 means excess or dysfunctional adipose tissue is there. If patient is having metabolic syndrome related risk factor, or patient is already having CKD related risk factor like microalbuminuria or stage 3 AB CKD, or patient is having hypertension, triglyceridemia or type 2 diabetes, then patient is already falling into stage 2. But when patient develops subclinical CVD, then patient is in stage 3, either in form of heart failure or ASCVD or high risk equivalents. And if patient is already having established CVD, then it is CKM stage 4. So CKM syndrome is a puzzle. We have initiator, we have amplifier and we have outcome. How? Metabolic dysfunction is the initiator. Chronic kidney disease is the amplifier, and cardiovascular disease is the outcome, because ultimately patient is having diabetes or patient is having CKD or patient is having heart failure, ultimately patient die of cardiovascular disease, and that's why it is basically an ultimate outcome of any person having CKM syndrome. And do we have answer with this? Just we discussed in our previous session also, we have an excellent molecule available with us in form of GLP-1 analog that is a solution for CKM. How? Let's discuss it out. As far as major actions of GLP-1 is concerned, GLP-1 is a drug which is going to have almost 4 to 6 times higher GLP-1 level. It can create that level inside the body when GLP-1 agonists are given. Now GLP-1 agonist will have effect on blood vessels, it will reduce blood pressure, that's why there is slight reflex tachycardia which may develop, but later on it is not causing any problem. It reduces gastric emptying and it also improves dyslipidemic profile. It also having action on alpha cell as well as beta cell. So it stimulates beta cells, but that is in glucose sensing action. So if sugars are high, it will stimulate beta cell, and it will also reduce glucagon secretion from alpha cell. So it reduces hyperglucagonemia. And more importantly, it acts on central nervous system, which no other anti-diabetic agent can work, which reduces appetite. As we were discussing, that it improves that hedonic eating, but it also increases satiety also. So first let's discuss about metabolic dysfunction, which is the initiator of CKM syndrome. GLP-1 reduces appetite, it induces weight loss, it induces less calorie intake, so there will be more energy, there will be deficit of energy, there will be lack of food entering inside the body while energy consumption will be going on, so there will be negative balance as far as calories concerned. To do this thing, GLP-1 stimulates POMC and CART, which reduces hunger, which reduces energy intake and food craving, and at the same time it also inhibits NPY, that is neuropeptide Y, and AGRP, which increases satiety. So If patient is taking GLP-1, patient will devoid of overeating, patient will have a preferred, the food preference will go on changing. Not only food, now it is been studied so long that it even reduces alcohol consumption also. So that is how GLP-1 works as far as brain level satiety and hunger suppression is concerned. Along with that, it is having direct effect that will improve endothelial function. It reduces vascular smooth muscle activation. It reduces vascular smooth muscle proliferation also. It reduces vascular inflammation and it reduces lipid accumulation inside the blood vessels. But at the same time, there are indirect effects in form of reduction in blood pressure, reduction in weight and reduction in HbA1c. All will also culminate in the same benefit of reducing inflammatory damage to vascular endothelial cell. GLP-1 RA exerts strong anti-inflammatory action, and that is through various pathway. It reduces interleukin 8, interleukin 6, NF-κB and TNF alpha, and thereby it reducing multiple inflammatory markers. So if we are giving GLP-1, it reduces the initiator, the dysglycemia, dysmetabolism inside the body. But patient is already having CKM stage 1 or I can say stage 2. Now it is going to amplify by kidney. So how at this juncture a GLP-1 can work? GLP-1 is having potential kidney mechanism of action. How? By indirect action like glycemic control, blood pressure control and weight control, exactly same what I discussed for metabolic control. But at the same time, it also increases natriuresis and it reduces kidney as well as systemic inflammation and oxidative stress, and thereby it is helpful at this juncture also. Now patient has already entered in stage 3 and 4 CKM. So when patient is suffering with the outcomes of CKM and now you still want to reduce CVD event, do we have data for that? Do we have mechanism of action to support this thing? Yes, we still have chance to reduce that cardiovascular risk. That GLP-1 receptor mediated cardioprotection, which is due to, obviously central nervous system is already going to play a role because it is GLP-1, it is always going to be there, but it reduces fatty liver, as my previous speaker Dr. A.K. Singh nicely described Essence study with injectable semaglutide also. It reduces fatty liver in excellent way. The kidney benefit, blood vessel benefit, atherosclerotic plaque related benefit, and direct effect on myocardium by reducing apoptosis and reducing inflammation. It works even at the juncture where patient is already having some degree of cardiac involvement which is already there, and still it can reduce cardiovascular outcome. So benefit of GLP-1 is extended beyond glycemic control and addressing multiple components of CKM, either be it brain, heart, vessels, liver, pancreas or kidney. So everywhere it is regulating, it is improving metabolic part, kidney amplification part as well as the outcome part. Now when we are talking about GLP-1 as a molecule for as an anti-diabetic agent or for reducing CKM risk, is guideline supporting all these things what I am talking about. EASL guidelines of 2024 support that GLP-1 RA as a preferred pharmacological option for management of type 2 diabetes and obesity. KDIGO guideline is also support GLP-1 after SGLT2 because we have excellent data with kidney protection with SGLT2. After SGLT2 for glycemic control, individualization if needed, GLP-1 is a preferred option. EASD and EAC is also supporting this drug to be used whenever there is higher cardiovascular or renal risk or CKM risk. So evidence of oral semaglutide in this CKM initiator, that significant HbA1c and weight reduction with oral semaglutide is there in Pioneer study. There are 19 clinical pharmacological trial, 1 phase 2 trial, 12 phase 3A trial and 1 phase 3B trial, and 7 out of 10 patients achieving HbA1c less than 7 in 6,645 patients who are exposed to oral semaglutide. So this is very important thing, and HbA1c reduction in comparison to placebo, you can see that is significant, almost 1.5% of HbA1c reduction, and patients who are losing 5 kg is also good number of patients. And if the entry level HbA1c is high, which is proven for many other oral antidiabetic also, if HbA1c, when patient is already having HbA1c baseline of more than 9, it can reduce HbA1c up to 2.6%. That is what data we have got. And when in pioneer study semaglutide was compared to multiple other agents, you can see pioneer 2, where it was compared to empagliflozin, 40% of the patient with semaglutide had HbA1c reduction of 1% with more than 5% of body weight loss. So dual goal of better HbA1c and weight loss was achieved in 40% with semaglutide, that is oral semaglutide. I am not talking about stronger injectable semaglutide, oral semaglutide, and in empagliflozin 25 milligram it was 20%. So as in comparison to liraglutide, in comparison to sitagliptin also, and obviously in comparison to placebo, this drug shows excellent HbA1c control and body weight loss of more than 5% in almost 2/3 of the patient, or sometimes half of the patient. As far as CV risk reduction is concerned, we have data where it reduces hsCRP, it improves lipid parameter, and it reduces systolic blood pressure, and 4.7 centimeter waist circumference reduction is noted with oral semaglutide. And that's why our Indian regulatory authority has approved oral semaglutide to be used in patient with uncontrolled diabetes. It can be used in more than 18 years of age. You can use it as first line also if other antidiabetic agents are contraindicated. It can be used as a monotherapy or in combination therapy. It can be used in patients with special population like hepatic or renal involvement. And this is very good thing about GLP-1, because GLP-1 is a molecule which is quite safe up to last stage of CKD and even last stage of hepatic disease. Only the decompensated cirrhosis or stage 5 or end stage renal disease which requires dialysis, where you should not use GLP-1, otherwise you can use, and it is cardiovascular safe. And these are real evidence data from Pioneer Real India study, where 90% were started for achieving better glycemic and weight control. Their mean HbA1c was 8.9, and 1 out of 2 patients were having CVD related history. And you can see the data of this real world study from India. HbA1c reduction 1.78%, body weight reduction 7.3%. Now when HbA1c is less than 9 and HbA1c is more than 9, again you can see 2.4% HbA1c reduction when HbA1c was more than 9 at baseline. So you are getting better results. So as for weight also, 6.8 kg and 7.5 kg respectively in less than HbA1c 9 and more than HbA1c 9. So you can have better glycemic control, and despite of that almost similar weight loss is possible. So just to conclude my talk, clinically significant improvement in glycemic control and reduction in body weight were observed overall and in 2 subgroups with baseline HbA1c of less than 9 and more than 9. New safety concerns are not observed from real world type 2 diabetes, and benefit risk balance of oral semaglutide remains positive. The study provides insight to how oral semaglutide performs its utilized in routine clinical practice, and you can use this drug in our routine type 2 diabetic patient. And as far as comparing this very important drugs, that is oral semaglutide, DPP4 inhibitor, metformin, and obviously not to forget SGLT2 inhibitor, just compare the overall scenario of these 4 drugs. Glucose lowering efficacy, highest with GLP-1, then SGLT2 metformin, DPP-4 is comparatively milder in comparison to all 3. Effect on body weight, +2 for SGLT2, but 3 to 4 kg, max to max 5-6 kg weight loss is possible. Here you are going to get more than 5% of body weight loss. CV risk reduction, CV risk factor reduction is also excellent with GLP-1, that is oral semaglutide, while it is mildly there with SGLT2. DPP-4 neutral, and metformin, actually we don't have any specific data, it may be beneficial. What about pleiotropic benefit? Pleiotropic benefit is excellent as far as oral semaglutide is concerned. It is there somewhat with SGLT2 inhibitor. Again, DPP-4 is neutral, metformin is neutral, and risk of hypoglycemia for all 4, it is negligible. We should not worry about that hypoglycemic risk. So if we consider this parameter, oral semaglutide is having tick mark on all 5 aspects of important anti-diabetic drug, anti-metabolic syndrome drug with CKM syndrome. Thank you.
Thank you, Dr. Piyush Dai.